morning. So continuing with the next part of our quick revision series, today we'll be discussing about rheumatology. Immunology and rheumatology is a very big class actually. We are not going to discuss it in detail. Only the basic diseases, how to approach them, we are going to discuss. So before starting rheumatology, this is the image given in Harrison. This is the entire summary of how our immune system works. So the hematopoietic stem cells divides into multiple aspects. With regard to immunity, we know that immunity has two basic parts: the non-specific immunity and the specific immunity. Non-specific immunity, we have many barriers, we have many cells. The important cells are neutrophils, macrophages and dendritic cells. So these lead to non-specific immunity, which is called as inflammation. When inflammation ends, the main function of inflammation is to activate the next line, which is the B cells, which is the lymphocytes. Lymphocytes may be T lymphocytes, B lymphocytes, NK cells or plasma cells. These in turn secrete many cytokines to have their downstream effects. T cell may be CD4 positive T cells, also called as helper T cells. CD8 positive T cells, also called as cytotoxic T cells. B cells mainly secrete immunoglobulins. B cells become plasma cells and they secrete immunoglobulins. We know that we have 5 types of immunoglobulins: G, A, M, E and D. Each has its own function. Now the CD4 is very important because the CD4 T helper cells can get differentiated into different types of T helper cells. For example, they can get differentiated into TH1 cell, which has a different action, TH2 cell, which has a different action. And we know very well that, especially in respiratory, when this TH2 type of response gets activated, we get bronchial asthma. This is called as TH2 asthma. There is another asthma where TH2 is not involved, that is non-TH2 asthma. Right? So why we should know is, every type of pathway, their mediators are different, the symptomatology is different, the treatment is different. And if you remember, if you know which interleukins are involved, we can identify which monoclonal antibody to use there. So that is a very big explanation. We are not discussing here to keep things simple. So we'll just stick here with the discussion of autoimmune diseases, right? So how all immunity can be affected. When immunity is low, it is called immunodeficiency disease. When immunity is high, autoimmune disease results, right? So we can classify autoimmune diseases into organ specific and systemic. So example for organ specific autoimmunity is, we'll take the easiest examples. Autoimmune thyroiditis. So it affects only the thyroid, it doesn't affect other organs. Myasthenia gravis. Myasthenia affects only the neuromuscular junction to cause effects, but it doesn't affect other organs. And we can also tell type 1 diabetes mellitus, where insulin secreting cells are destroyed by autoimmunity. So these are examples for organ specific autoimmune diseases. And we have systemic autoimmune diseases. So the common systemic autoimmune diseases, for ease of understanding, I have classified into multi-organ diseases. So under this we have 3 examples. One is SLE, systemic lupus erythematosus, so the famous disease. Then we have another S, systemic sclerosis, and another S, Sjogren syndrome. So these 3 diseases we will be discussing under systemic multi-organ diseases. Now again, systemic diseases can lead to arthritis. Only multiple joints are involved. So the systemic autoimmune diseases which present as inflammatory arthritis. Under this category, we have rheumatoid arthritis, which is the main class, and we have another category called as seronegative arthritis. Seronegative arthritis, we have axial spondyloarthritis. The main disease here is ankylosing spondylitis, ankspons. Then we have 4 appendicular spondyloarthritis. They are psoriatic arthritis. Remember, psoriasis itself is an autoimmune disease. Psoriatic arthritis, reactive arthritis, IBD related arthritis. So these are the appendicular spondyloarthritis. The next category will be diseases involving the muscle. That's called as myositis diseases. So here we have many diseases like dermatomyositis, polymyositis, inclusion body myositis. Then we have something called as anti-synthetase syndrome. Then the fourth category is vasculitis, that is autoimmune diseases involving the blood vessels. So this will go under a very big classification. Okay, so this will be a broad categorization because we are going to discuss all the diseases under these headings only. Okay, so we will go one by one. So this table tells about the specific organ specific autoimmune diseases. So what is the antibody produced and which it affects? So we know very well that acetylcholine receptor antibody is there in myasthenia gravis. I'll just underline the important ones. And collagen type 4 alpha 3 chain, the antibody is produced in Goodpasture syndrome. And in dermatology we have desmoglein 1 and desmoglein 3. Desmoglein 1 comes in pemphigus foliaceus, desmoglein 3 comes in pemphigus vulgaris. Type 1 diabetes, we have many antibodies, right? GAD65 is one commonly used antibody. IA, insulin antibody 2 is another one. So GAD65 and insulin antibody 2. Of course, anti-insulin antibody is also there. There's something called as Hirata's disease, insulin hypoglycemic syndrome, like patients who are taking insulin for a longer time. That insulin itself is a foreign substance. Injected insulin is a foreign substance. So antibodies will be produced against the injected insulin. That will affect our endogenous insulin. So when insulin falls, there will be some symptoms. That antibody will stimulate insulin and there will be hypoglycemia, right? So that is called Hirata's disease, insulin hypoglycemic syndrome. There will be antibodies against insulin. Then we know the intrinsic factor type 1 produces pernicious anemia. Intrinsic factor is needed for B12. When there is antibody against intrinsic factor, B12 is not absorbed. Okay. And antithyroid peroxidase, TPO antibodies for autoimmune thyroiditis or Hashimoto's thyroiditis. Antithyroid globulin antibodies also seen. But in Graves' disease, we have TSH receptor antibody. It is a stimulating antibody. TSH receptor antibody. So among all these things, we have few blocking antibodies, few stimulating antibodies, right? For example, acetylcholine receptor antibody in myasthenia gravis is a blocking antibody. That antibody binds to the acetylcholine receptor and inhibits its action. Whereas in Graves' disease, it is a stimulating antibody. The antibody binds to the TSH receptor and it stimulates, causing hyperthyroidism. Tyrosinase is for vitiligo. And okay, so these are the important things. We have so many other things, we are not going to discuss that because these are the ones which are commonly asked in multiple scenarios and they are important. So this is what I was telling you. So we discussed about the organ specific autoimmune diseases and their particular antibodies. I told you the mechanism can be either blocking or inactivation or stimulation. For example, myasthenia gravis is a blocking antibody. We have antiphospholipid antibody syndrome because phospholipids are needed for the normal clotting mechanism. When antiphospholipid anti is there will be problems in clot formation and thrombolysis. And intrinsic factor antibody, pernicious anemia is a blocking antibody mechanism. And the main important example for stimulating antibody is Graves' disease, TSH receptor antibody. And desmoglin 3, which occurs in pemphigus vulgaris, it's a stimulating antigen. Okay. Hashimoto is also a destroying antibody, but the antibody doesn't destroy, it leads to cellular cytotoxicity. It's enough if you remember, Hashimoto's is also a destroying antibody. Okay. So again, just a revision. Graves' disease we just discussed. Hashimoto's we discussed. Type 1 diabetes mellitus we discussed. And pemphigus we discussed. Autoimmune hemolytic anemia, pernicious anemia, multiple sclerosis. Even rheumatic fever is due to molecular mimicry. It is also an autoimmune disease. Goodpasture syndrome, which comes in nephrology. And the non-specific diseases, SLE, rheumatoid arthritis, vasculitis, antiphospholipid syndrome. So all these are the non-organ specific or systemic autoimmune diseases. So we finished the organ specific autoimmune diseases. That was just a revision. Now, before understanding about the systemic autoimmune diseases, we should understand the concept of autoantibodies, because there are so many autoimmune diseases, so many systemic autoimmune diseases which we discussed. But how will you diagnose them? Diagnosing them is by clinical features. There are some specific clinical features to pick up each disease. Then the basic lab will give us some clues. The basic lab evaluation, for example, ESR and CRP. These are some basic markers which, if they are elevated, we can get an idea that there may be an autoimmune disease. Then we have specific testing is by autoantibody testing. So we can do autoantibody testing. One way by which you can test autoantibody is the immunofluorescence. We put a dye, immunofluorescent dye, and we look under the microscope. We see the pattern of involvement. Because antinuclear antibodies, all these are antinuclear antibodies. ANA. So there are many types of antinuclear antibodies. All the antinuclear antibodies bind to some part of the nucleus and they cause damage, they cause the systemic symptom. So ANA is the general term. So it is a screening test. So when someone says ANA, it is not a diagnostic test because there are many antinuclear antibodies. There are many types of antinuclear antibodies. So if ANA is positive, it is a screening test which helps us suggest that there is some autoimmune disease. Then we have some special subtypes of antinuclear antibody. One is anti-double stranded DNA. DNA is part of a nucleus. So anti-DS DNA is there. This is highly specific for SLE. So if DS DNA is positive, it indicates it is specific for DS DNA. It is not only specificity, but also it correlates with disease activity and nephritis and vasculitis. So if DS DNA is positive, it means that patient may have involvement of vasculitis and nephritis. I'll underline the important antibodies. Anti-Smith. SMS anti-Smith antibody. So it is also specific for SLE. We have RNP. especially we say it as U1 RNP. Comes in a disease called as MCT, mixed connective tissue disorder. Then we have anti-Rho and anti-La. Anti-Rho is called as SSA. SS is Sjogren syndrome. So SLE itself can lead to Sjogren syndrome. I told you that Sjogren syndrome is a separate systemic autoimmune disease, but there is something called a secondary Sjogren syndrome. SLE itself can produce basically picture of any autoimmune disease. So when anti-Rho and anti-La is associated, the person with SLE is having Sjogren syndrome. Or when DSDN is negative and only anti-Rho and anti-La is positive, it means patient is having Sjogren syndrome. Why this anti-Rho or SSA is important is it is associated with neonatal lupus. Neonatal lupus has congenital heart block. Then antiphospholipid antibody. There are 3 antiphospholipid antibody. We will discuss that shortly. Okay. So these are some of the antibodies. So apart from knowing the names of the antibodies, their clinical importance, we should know this pattern of involvement. Because all these are anti-nuclear antibodies only. So these antibodies bind to some part of the nucleus. Now, I'll make it simple. Nucleolus is a part of nucleus. So some autoantibodies are in the nucleolus. So I'll tell you those antibodies later. So there are some antibodies which are in the nucleolus. So only the nucleolus will be stained while seeing under the microscope. So nucleolus will present like this, a large clumpy aggregates. Centromeres will be multiple small dotted appearance. So anti-centromere antibodies. So anti-centromere antibodies is a feature of systemic sclerosis, limited systemic sclerosis. Then we have speckle pattern. Like some antibodies will target the entire DNA. Example, double-stranded DNA. DNA is present throughout the nucleus. So this anti-dsDNA will be a speckle pattern, it will be diffuse. The other things also, anti-SCL70, Jo1, anti-Rho, these are all speckle pattern. Some may be homogeneous, some may be peripheral. So some questions may be asked regarding the pattern. So there are some nucleolar patterns, there are some centromere patterns. Example, Crest syndrome is centromere pattern. This anti-Rho, anti-La are speckle pattern. Anti-dsDNA may be speckled or homogeneous pattern. So we must try to understand the particular pattern. So ANA is a screening test. We have some specific test also. We should know the titer as well as the pattern. So coming to individual diseases now. So among systemic autoimmune diseases, we are going to discuss SLE now. So there's a classification in SLE that we call it as SLIC classification. Systemic Lupus International Collaborating Clinic Criteria for Classification. In that we have 11 systemic clinical manifestations and few lab manifestations. So it can be given by the mnemonic MD SOAP brain. So like M is the malar rash. D stands for dermatitis. S is serositis. O is oral ulcers. A for alopecia. P for pleuritis. Pleuritis and serositis can be taken together. B is there are brain findings. R is RBC cast in urine. A is there is anemia, that is hemolytic anemia. And N can be taken as neurological findings. Okay. Or there is another way to remember this. There are changes in practically every organ. In skin, there are rashes. The typical rash is the malar or the butterfly rash. There are 4 skin findings actually. So one is the malar rash, which is the typical rash we know. There can be discoid-like rash. There is alopecia and oral or nasal ulcers. Even that can be taken as a skin finding. Then we have synovitis and serositis. Synovitis is joint involvement. So next to skin, we have the joint. Then we have serositis. Practically any membrane can be involved. Pleuritis, pericarditis. The renal involvement is very, very important because there is a separate entity called as lupus nephritis. Kidney is the commonest, one of the commonest organ which is involved in lupus. So there we have proteinuria, RBC cast, right? Proteinuria and RBC cast. Then neurological findings, we have psychosis, seizures. Then hematological findings. So the brain is involved, kidney is involved, joint is involved, skin is involved, and the blood is involved. So in addition to some of these clinical features, in addition to 4 of these clinical features, we should have the immunological manifestation. So I told you ANA is the screening test. So ANA should be positive and dsDNA should be more than twice. Anti-smooth muscle antibody. Then anti-phospholipid can be positive or some of these can be positive. So this is the SLIC criteria for SLE. So SLE is one of the systemic autoimmune diseases. So there is, I told you kidney is the important organ involved in SLE. So we have lupus nephritis, kidney involvement. There is a classification, International Society of Renal Pathology. That society has given a classification. Class 1 is minimal mesangial. Class 2 is mesangial proliferative. Class 3 is focal lupus nephritis. Class 4 is diffuse lupus nephritis. 5 is membranous. 6th is advanced sclerotic. So just remember the names at least. So while discussing about SLE itself, we should discuss about APLA, anti-phospholipid antibody syndrome. So why this anti-phospholipid antibody syndrome is there is, it is one disease which causes multiple clots in the body. It is one of the hypercoagulable state. So again, it is one of the antibodies which is linked in the clotting mechanisms. So among anti-phospholipid antibodies, we have 3 antibodies. One is anti-cardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulation. So ACL antibody, that is anti-cardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant. These are the 3 anti-phospholipid antibodies. Now we have a criteria which is given. We have criteria for anti-phospholipid syndrome. In that, the lab criteria is easy to remember. I told the 3 antibodies, lupus anticoagulant, anti-cardiolipin, and anti-beta-2 glycoprotein. So in that, these antibodies should be significantly positive on 2 occasions more than 12 weeks apart. That's the simplest way to remember. So lupus anticoagulant, anti-cardiolipin, beta-2 glycoprotein, the antibody should be positive on 2 occasions more than 12 weeks apart. In that, any 2 is taken. 1 is taken. Then there should be 1 clinical criteria. So it is 1 clinical and 1 lab. The clinical, I told you, there is clots everywhere. APLA is known because it is one of the conditions, one important condition causing recurrent pregnancy loss. So the pregnancy criteria is at least 1 unexplained abortion, at least 3 unexplained consecutive abortions. That is important. There should be 3 consecutive spontaneous abortions, or 1 unexplained fetal death, or 1 unexplained premature birth. So all this occurs because there is clot in the placenta. So when there's a clot in the placenta, there will be fetal hypoxia. So 3 consecutive abortions, 1 premature birth, or 1 unexplained fetal death. This is the pregnancy criteria. Any one of this is enough. Then, or there can be clots anywhere. So any one arterial clot, venous clot, or small vessel thrombosis in any organ. So which are the organs where can be clotting? So we know about deep vein thrombosis. There can be pulmonary embolism. There can be even superficial thrombophlebitis. Not a deep vein, it is superficial thrombophlebitis also can be there. In artery, they can have stroke, they can have TIA, they can have MI, they can have peripheral arterial disease and digital gangrene. There can be retinal artery involvement, that is amaurosis fugax. So practically arterial thrombosis of any organ, right? It could be mesentery, it could be heart, it could be brain, it could be eye. So that is venous arterial. Or they are given some scoring systems also for that, right? And obstetric manifestation is important. So that is about SLE and the related condition, which is antiphospholipid antibody syndrome. So treatment, actually it is very easy to remember. One, based on the organ we are going to give treatment. So most of the things will be steroids and immunosuppressants. Because we are going to suppress the immunity. So we are not discussing the treatment regimens here, because lupus nephritis has a specific treatment regimen on its own, right? Okay, so this finishes one systemic autoimmune disease, which is SLE. Now the second systemic autoimmune disease which we are going to discuss today is systemic sclerosis. Systemic is all over the body. Sclerosis is there is fibrosis everywhere. So systemic sclerosis is an autoimmune disease which causes fibrosis everywhere. So what are the organs which can be fibrosed? Mainly skin is fibrosed. So when skin is fibrosed, what happens? There can be calcinosis cutis. Skin becomes thick. Okay. Vessels can be sclerosed. When vessels are involved, we have some phenomenon called as Raynaud's phenomenon. Raynaud's phenomenon is the digital arteries go for vasoconstriction when exposed to cold or cold water. So when this happens for a longer time, what happens? The digital arteries go for thrombosis and there will be digital ischemic ulcers. Don't confuse Raynaud's phenomenon versus Raynaud's syndrome or Raynaud's disease. Raynaud's disease is not an autoimmune disease. It is a primary vascular hyperreactive disease where on exposure to cold or cold water there will be vasoconstriction which reverses on exposure to warmth. But Raynaud's phenomenon is an autoimmune condition and due to underlying secondary disease. I told you SLE can practically cause anything. There can be rheumatoid arthritis which can cause Raynaud's phenomenon, but one typical disease which causes Raynaud's phenomenon is systemic sclerosis. The difference between Raynaud's phenomenon and Raynaud's disease is Raynaud's disease, even though it causes discoloration, initially there will be whitish coloration because of vasoconstriction, then there will be hyperemia, and due to venous congestion there will be bluish color. In spite of discoloration, there can never be ulcers, but Raynaud's phenomenon will cause digital ischemic ulcers, right? So if you remember skin becomes thick, and remember calcinosis cutis. Vascular, if you remember, think of Raynaud's phenomenon and digital ulcers. Then what happens in lung? Lung, we have two important diseases. Interstitial lung disease can occur. If you remember pulmonology discussion, autoimmune disease causing interstitial lung disease will be of the NSIP pattern, non-specific interstitial pneumonia. This usually responds to steroids. Then we have pulmonary arterial hypertension. Again, thinking of pulmonary hypertension in systemic sclerosis will be group 1 pulmonary hypertension. So the skin, vascular, pulmonary. Of course, other organs are also involved. GIT is important because when the esophagus becomes thick, there will be swallowing difficulty. When swallowing difficulty is there is chance of aspiration pneumonitis. One important treatment is, apart from the disease modifying treatment which we give, proton pump inhibitors play an important role in systemic sclerosis because to prevent aspiration. At least remember these 4 organs which are involved in systemic sclerosis. And systemic sclerosis is classified into 2 types. Limited systemic sclerosis and the other one is diffuse systemic sclerosis. There is something called as CREST syndrome. CREST is nothing but another term for limited systemic sclerosis. This CREST stands for calcinosis. I told you calcinosis cutis. What is calcinosis cutis? Skin becomes thick and calcified. That is calcinosis cutis. R is the Raynaud's phenomenon. E is the esophageal dysmotility. This also we discussed. S is sclerodactyly. Sclerodactyly is the fingers become fibrous. When fingers become fibrous, they become like sausage. That is called as sausage digits. T is telangiectasia. That is blood vessels become thick. So the blood vessels in the face and the nails, etc., they become dilated. That is called as telangiectasia. So this is CREST syndrome. Of course, the same findings can also occur in diffuse systemic sclerosis. But what is the thing is the extent of skin involvement. In limited systemic sclerosis, only a part of the skin is involved. But here, literally the entire body is involved. And these findings, the esophageal dysmotility, Raynaud's phenomenon, sclerodactyly, these are very prominent in limited systemic sclerosis. Whereas even though the entire body is involved in diffuse systemic sclerosis, these above findings will be mild. And limited, when things are limited, it will be more centralized. So just a mnemonic to remember, anti-centromere antibody. Limited systemic sclerosis will be focused, so it has anti-centromere antibody. And since the word centromere comes here, what pattern you can see in immunofluorescence? There will be centromeric pattern in immunofluorescence. And here we have anti-SCL70. This will be a speckled pattern. So if scenarios are given with these clues, we can figure it out. So this is what I was telling. We have limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. In limited, skin involvement will be limited. It will be limited to the fingers. And what the finger involvement is called as sclerodactyly or sausage fingers. So it will be fingers distal to the elbows. But in diffuse systemic sclerosis, everything. The extremities, face, trunk, everything. Raynaud's phenomenon is very prominent in limited systemic sclerosis. Calcinosis cutis is prominent in limited systemic sclerosis. So what about diffuse systemic sclerosis? Arthralgia is severe, ILD is severe, pulmonary artery hypertension will be severe. So the antibody we see is anti-centromere antibody, and the antibody which we see in diffuse systemic sclerosis is SCL70. SCL70 is also called as anti-topoisomerase 1. Another antibody is anti-RNA polymerase. See, this is the immunofluorescence pattern. So this is the anti-centromere pattern. And anti-SCL70, it is showing a diffuse pattern. So in image-based questions or when clues are there, you can correlate this one. Okay, so anti-centromere will be a centromeric pattern like this. Anti-SCL70 will be a diffuse pattern. See image E. This is nucleolar pattern. Anti-RNA polymerase 3 because polymerase is present in the nucleolus. Okay. Right. So we'll see some pictures together. If a picture is shown like this, person is having an autoimmune disease. These are the digital ulcers. So I told you, in Raynaud's disease, there will not be digital ulcers. In Raynaud's phenomenon, secondary to autoimmune disease, especially systemic sclerosis, there will be digital ulceration. So this is Raynaud's phenomenon. So see, in the nails, the vessels are dilated. This is nail bed telangiectasia. Nail bed telangiectasia. So telangiectasia is dilatation of blood vessel. It is one of the feature of CREST syndrome. This is facial telangiectasia. See, blood vessels are dilated over the face. So facial telangiectasia. So it is also prominent in limited systemic sclerosis. So what is this? This is interstitial lung disease, right? If you see, I told you in NSIP pattern there will be predominant of ground glassing and reticular shadowing. See, can you see the ground glassing here? Ground glassing is the lung opacity through which underlying vasculature can be seen. So this is a ground glassing. So ground glassing is there. When ground glassing becomes severe in late stages, we can get honeycombing. But honeycombing occurs earlier in UIP pattern or idiopathic pulmonary fibrosis. So what is this? The entire fingers are distended like sausage. So this is sausage finger. So can you see here? Because of digital ischemia, the bones have been resolved. So this is Raynaud's phenomenon. Raynaud's phenomenon, which is given in X-ray form. This is the calcinosis cutis. Skin becomes thick and calcified. So this is calcinosis cutis. The calcinosis cutis is seen in a reconstructed X-ray like this. Calcium deposits everywhere. Calcinosis cutis. Right? So this finishes the second systemic autoimmune disease, which is systemic sclerosis. The third systemic autoimmune disease which we are going to discuss today is Sjogren's syndrome. So our approach to every autoimmune disease is how does it present, what antibody we are seeing, what is the pattern of involvement, and we are not discussing the treatment, right? So Sjogren's syndrome, what is the clinical manifestation? Definitely it's an autoimmune disease which mainly affects the glands. So the two important glands are the glands in the eye, that is lacrimal gland, and the salivary glands. When lacrimal glands are involved and destroyed, this is destroyed due to lymphocytic infiltration. So the lacrimal glands and salivary glands are destroyed by lymphocytic infiltration. When lacrimal glands are destroyed, it leads to dry eye or xerophthalmia. There are many causes of xerophthalmia, like vitamin A deficiency, etc. But autoimmune disease causing xerophthalmia is Sjogren's syndrome. Salivary glands, when is involved, there is dry mouth, also called as xerostomia. This predisposes to infection. So the sole clinical presentation itself will be like that of dry eye and dry mouth and symptoms related to it. So we should be very cautious in diagnosing this one. So this is because of glandular involvement. Now how will you diagnose, or what is the gold standard to prove that there is lymphocytic infiltration of glands? So in eye we would have heard about the term Schirmer's test, but that is going to only give a clue. The lip biopsy or the minor salivary gland biopsy is the gold standard. It is done to prove. But which investigation gives us clue? Definitely the antibody testing. So we are discussing about anti-Rho and anti-La. Anti-Rho is SSA, Sjogren's syndrome A. Anti-La is Sjogren's syndrome B. Of course, anti-Rho and anti-La are also antibodies which may be present in SLE. When SLE plus Sjogren's is present, it is called as secondary Sjogren's. When SLE is not present, that is anti-DS DNA is absent, only Sjogren's is present, we call it as primary Sjogren's. So Sjogren's may be primary Sjogren's or secondary Sjogren's. Of course, RA plus Sjogren's is secondary Sjogren's. SLE plus Sjogren's is secondary Sjogren's. Only Sjogren's is primary Sjogren's. Of course, there can be other manifestations also. Joint pain may be present. There may be lymphocytic interstitial pneumonia. Right? There is lymphocytes everywhere. There may be lymphocytic deposits in the liver, spleen, etc. Kidneys may be involved. But still, the two most important organs is eye and the lip. So see, this is how you proceed. So if there is dry eye and dry mouth, this is the main diagnostic symptom. There may be joint pain, there may be Raynaud's, there may be other salivary gland involvement, there may be kidney involvement. Whatever it is, we have to, if there is dry eye, we are going to see Schirmer's test. So that is like a screening test only. Then we can do an ocular staining, Rose Bengal staining, etc. Then we are going to see an unstimulated salivary flow. But these are only screening tests. Two important things which we are going to do is minor salivary gland biopsy or lip biopsy, which is the gold standard, and we are going to see anti-Rho and anti-La. If any of this is present, we call it as Sjogren syndrome. Of course, we have to rule out the other secondary causes. Right. So this finishes Sjogren syndrome. So treatment again will be simple. One, we are going to give immunosuppressants, steroids. Then we are going to treat the symptoms. What symptom is there? There is dryness. So we have to increase secretion. When parasympathetic organ is stimulated, there will be secretion. So we are going to give pilocarpine. It is a parasympathetic agonist. Okay. So with this we finish the 3 systemic autoimmune diseases. Now since we finished that, we will come to the second category. So I was telling you, the second category is arthritis or joint pain. What is meant by the term inflammatory arthritis? See, arthritis means swelling, pain in the joint, right? Inflammation of the joint, like swelling and pain in the joint is arthritis. So we have 2 types of arthritis: inflammatory joint pain or non-inflammatory pain. So just remember 3 important features. Pain which is present in the early morning or rest, because we usually sleep in the night or in the early morning. So late night pain or early morning pain or rest pain relieved with rest plus there is associated early morning stiffness more than 30 minutes, which is relieved with activity. Relieved with activity. There is pain at rest, which is relieved with activity. EMS more than 30 minutes is inflammatory pain. Non-inflammatory pain is the opposite. There is pain on activity, either standing or walking. There is pain on activity, relieved with rest, and there is early morning stiffness less than 30 minutes. This will be non-inflammatory pain. Okay. So why we have to classify this inflammatory versus non-inflammatory pain is because there are so many causes of pain. Osteoarthritis can cause pain, which is a degenerative joint disease. The rheumatoid arthritis, spondyloarthritis, etc. can cause joint pain. They are the inflammatory or autoimmune diseases causing arthritis. Gout, etc. can cause arthritis. They are the crystal-associated arthritis. Pain can occur even without any of these diseases. That is called as fibromyalgia. So fibromyalgia is one of the pain syndromes where there's a specific criteria for fibromyalgia, like there is sleep disturbance, REM sleep abnormalities, etc. So pain can occur even without any of these things. Only if you classify inflammatory and non-inflammatory, because if you classify as inflammatory, we have one of these 5 diseases only. So if there is inflammatory arthritis, it could be either RA or seronegative arthritis. What is meant by seronegative? In rheumatoid arthritis, we have 2 important tests. One is RA factor, rheumatoid arthritis factor, which is an IgG antibody. Next one is anti-CCP, anti-citrulline C protein. These 2 are the antibodies which are usually used to diagnose rheumatoid arthritis. In seronegative arthritis, this particular 2 antibodies are absent. So RA factor and anti-CCP, these 2 are negative. That is why these are called as seronegative arthritis. Apart from that, these group of diseases have some few features in common. For example, these may be associated with HLA-B27. Remember, maybe for exam point of view, HLA-B27 positivity may point towards seronegative arthritis like ankylosing spondylitis or reactive arthritis, etc. But HLA-B27 need not be positive. But if HLA-B27 is positive, it is invariably seronegative arthritis. There is something called as enthesitis. What is enthesis? Enthesis is the point where the tendon joins with the bone. So how does tendon joins with the bone? Through capsules or ligaments. So there is pain in the ligaments. That is called as enthesitis. Okay. So these are some of the common features of seronegative arthritis. So we will discuss with this one. So in scenarios given about pain, think whether it is inflammatory pain or non-inflammatory pain. If it is inflammatory pain, try to think whether it is RA or seronegative arthritis. Now how will you fix that it is RA? So we have clinical criteria. See, this is the image showing rheumatoid arthritis. In rheumatoid arthritis, the proximal interphalangeal joint is commonly affected. Okay, in RA, PAP is involved. Please remember this one. PAP and metacarpophalangeal. So MCP and PAP joints are involved. So at least remember in RA, PAP is involved. Because in contrast to this, psoriatic arthritis, DIP is involved. This rheumatoid arthritis is actually a polyarthritis. Of course, it is an inflammatory because we discussed what is inflammatory pain. So it is an inflammatory polyarthritis. So multiple joints are involved, usually involving small joints of hand. So what joints of hand? Metacarpophalangeal joints and proximal interphalangeal joints. So it is not only inflammation because the synovium is involved and there will be deformities. So initially there will be inflammation and pain, later it leads to deformities. So there are so many deformities like swan neck deformity, Boutonniere deformity. Boutonniere is buttonhole deformity, Z deformity. So whatever it is, some deformity is there. In X-rays you may discuss, in ortho you may discuss, but whatever deformity is there, any problem in the hand joint, especially MCP and PAP, it is rheumatoid arthritis. Of course, other joints also can be involved. See, this is the criteria which is given. There is a scoring system. So the scoring is given based on joint involvement, based on serology, acute phase reactance and duration. So what joint involvement? I told you multiple small joints is typical. So what is meant by multiple? When more than 10 joints are there, 5 points are given. When 4 to 10 joints are there, 3 points are given, right? So multiple small joints. Of course, large joints are also given. If one large joint is involved, it is not RA. Remember, monoarthritis is never RA. Monoarthritis is never RA. It could be either reactive arthritis or septic arthritis. Septic arthritis is infection of the joint. Or it could be gouty arthritis. Gouty is a crystal deposition arthritis. That also we will discuss. Okay. So multiple small joints is only RA. A single joint cannot be RA. Of course, oligoarthritis. Few small joints or few large joints could be. Next is serology. I told you RA is seropositive disease, right? Either rheumatoid arthritis is positive or anti-CCP is positive. So based on the titer, points are given. Negative RF, negative anti-CCP is 0 points. Acute phase reactance. I told you, we always start with the symptoms, basic test. The basic test is ESR and CRP. High ESR, high CRP, of course points towards, but it acts only 1 point. Okay, the multiple small joint involvement with RA CCP positivity is rheumatoid arthritis. And duration less than 6 weeks is never RA. Always remember to tell the criteria of inflammatory polyarthritis, the duration should be more than 6 weeks. If it is less than 6 weeks, it is not RA, right? So when put together, RA is actually inflammatory small joint polyarthritis with RA or CCP positivity with ESR or CRP positivity more than 6 weeks. So even if you don't remember the scoring, that is immaterial. You should understand how the scoring is given, right? So this was the clinical image I gave you. Now see, this is the X-ray image. So one finding which you can pick it up here is, see the periarticular. See, this is the joint, right? This is the proximal metacarpophalangeal joint. See the bone around the metacarpophalangeal joint. It seems to be eroded. So there is periarticular osteopenia. In metacarpophalangeal, of course, some amount you can see in the, this is the PIP. In DIP, you are not able to see. Metacarpophalangeal joint also, you are able to see the osteopenia, right? So there is periarticular osteopenia of the MCP and PIP. So this is classically RA. Why this periarticular osteopenia? I told you, inflammatory polyarthritis is actually there is antibody deposition, more amount of inflammation is going on. Inflammation, there will be always increased blood flow or hyperemia. That increased blood flow erodes the bone. That is why we have osteopenia. So if an X-ray is given, of course we can look for the deformities. So some deformities here, right? It looks like an Z. There is some deformity here, but apart from the deformity, if you have to pick up one finding, it is the periarticular osteopenia, because hyperemia erodes the bone. Of course, if the same finding, if there is osteopenia of the distal interphalangeal joint, a particular sign is given called as penicillin cup sign, penicillin cup. That is, distal interphalangeal joint is involved, then that is psoriatic arthritis, right? Psoriatic arthritis is also an inflammatory arthritis, so there will also be a periarticular osteopenia, but that will involve the distal interphalangeal joints. So we didn't discuss the treatment aspects of other diseases, but treatment discussion of rheumatoid arthritis is important because there is a terminology called as DMARDs, disease modifying anti-rheumatoid drugs. It's of two types: non-biological DMARDs or classic DMARDs. Classic DMARDs were the drugs which were used initially. And we have the biological DMARDs. Biological is the tyrosine kinase inhibitors or the monoclonal antibodies which are used. See, hydroxychloroquine, sulfasalazine, methotrexate. Sulfasalazine is an NSAID, aspirin-based drug. Hydroxychloroquine is an anti-malarial. We have methotrexate, it is an immunosuppressant. Leflunomide. So these are the classical NSAIDs, classical DMARDs. Of course, treatment starts like this. We have to relieve the pain, that is by paracetamol or NSAIDs, like that. And non-medical measures like massage or physiotherapy, etc. Then we have the disease-modifying drugs, that is DMARDs. So either we give one among these drugs, steroids or hydroxychloroquine or sulfasalazine or methotrexate or leflunomide. Then we have the biological DMARDs. So TNF-alpha inhibitors. So we have infliximab, adalimumab, etanercept, golimumab, certolizumab. Then we have anakinra, which is an interleukin-1 antagonist. Rituximab is anti-CD20. Most of the CD20 is present in B cell. So most of the autoimmune diseases, like even multiple sclerosis or practically any autoimmune disease, the final step will be rituximab, because B cell is the cell which produces antibody. So when anti-CD20 is there, B cell gets destroyed. Then we have interleukin-6 inhibitors, tocilizumab. You would have remembered from COVID times. So these are the biologicals, monoclonal antibodies. Then JAK inhibitors. What is JAK? Janus kinase. It is the downstream signaling molecule of. So when TNF-alpha or interleukin-1 binds to its receptor, there will be downstream signaling of JAK, Janus kinase. and that is inhibited by giving drugs like tofacitinib, then or baricitinib or upadacitinib. They are also acting like biologicals. So nowadays this tofacitinib is commonly used because baricitinib is also available. Okay. So that was about biologicals. In rheumatoid arthritis also there is multi-system involvement. So apart from joints, other organs also can be involved. See the eye and the mouth, I told that xerostomia and xerophthalmia can occur with RA also. That is called as secondary Sjogren's. Rheumatoid arthritis with secondary Sjogren's can occur. In the lung we can have pleural effusion. So what type of pleural effusion occurs is rheumatoid arthritis is that is bilateral exudative. Usually exudative pleural effusion is unilateral, but in rheumatoid arthritis or in autoimmune diseases we have bilateral exudative effusion, and that effusion is a very low glucose effusion. If you see the glucose level, it will be very low, less than 10 or 20. We can have pulmonary nodules. We can have interstitial lung disease. So what type of pattern of interstitial lung disease? RA is an exception because in all other autoimmune diseases we have NSIP pattern, but RA is the only autoimmune disease which has UIP pattern of ILD. In heart there can be serositis like pericarditis. It can involve the kidneys. It can cause osteoporosis. There can be rheumatoid vasculitis. There can be anemia. So at least remember secondary Sjogren's and pulmonary effusions ILD. So now coming to the seronegative arthritis. So as I told you, seronegative arthritis, there are 4 main diseases: ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and IBD related arthritis. That ankylosing spondylitis affects the axial skeleton, that is the pelvis and the spinal cord. The other affect the other joints, appendicular skeleton. So this is what is the classification for axial spondyloarthritis. So again here the criteria is that should be back pain for more than 3 months. In rheumatoid arthritis the duration is 6 weeks. So here the criteria is back pain should last for 3 months and age of onset is less than 45. So the thing is there should be sacroiliitis on imaging. Okay. So sacroiliitis is the initial imaging finding. The imaging here is MRI, because initially in olden days we used to tell the bamboo spine. So X-ray finding of bamboo spine, there will be spondylitis, thickening of the vertebral column. But this is actually a late finding which is picked up in X-ray. But now with newer MRI can pick up the active inflammation, that is sacroiliitis. So there should be back pain more than 3 months, age of onset less than 45 years, and sacroiliitis on imaging, plus there should be at least one spondyloarthritis feature. So I was telling you, so spondyloarthritis, the common feature is there is HLA-B27 positivity, there is inflammatory back pain. So definitely it's an inflammatory arthritis, so inflammatory pain should be there. Enthesitis should be there with arthritis. So enthesitis is place where ligaments join with the bone, so like heel pain, etc. And there should be anterior uveitis. So uvei is one of the organs which is involved in seronegative arthritis. Like we saw, Sjogren's syndrome can occur in RA, uveitis can occur in spondyloarthritis, and dactylitis can occur. There can be psoriasis, Crohn's disease, because this will each point towards a particular disease. If there is psoriasis, it is psoriatic arthritis. There is Crohn's or ulcerative, it is IBD arthritis. There should be good response to NSAIDs. There should be family history of SPA. HLA-B27 is positive and elevated CRP. So important feature here is enthesitis should be there, uveitis should be there, HLA-B27 positivity should be there, dactylitis may be there. Okay. So this is the imaging finding. So I was telling you. So this seems to be a normal X-ray, but an X-ray cannot pick up the early sacroiliatic changes. So this is the late phase. See, here you can see the That's the femoral joint. This is the sacroiliac joint, right? Sacrum, ilium. You can see the sacroilium. But see here, there is fused and sclerosis. So this is the sacroiliitis, which is typical of spondyloarthritis. It is picked up early in MRI. You can see the sacroiliac joint edema. And this is the late finding, bamboo spine. That is complete ankylosis, that all the spine joints are, vertebral joints are fused. So this is like a bamboo spine. So there are many radiological differential diagnoses for this bamboo spine. Like even fluorosis can cause. There's something called as DISH, diffuse skeletal hyperostosis. Okay. We have something called as, now coming up to psoriatic arthritis, Caspar criteria, like nearly the same features. So there should be current, personal or a family history of psoriasis. It is not necessary that they should have psoriasis now. They may have psoriasis now, they could have had psoriasis previously, or even there is a family history of psoriasis is enough. And there should be nail changes. And there should be negativity for rheumatoid arthritis. And since psoriatic arthritis is also spondyloarthritis, dactylitis, enthesitis, etc. can be there. And juxta-articular new bone formation. This is the finding which I was telling you, penicillin cup sign. So DAP involvement. So either current history, past history or family history of psoriasis with nail changes, and DAP involvement will be psoriatic arthritis. Okay, so this is the criteria which we are telling about spondyloarthritis. Something about reactive arthritis. So reactive arthritis is also seronegative arthritis. So RA, ASO will be ASO, and anti-CCP will be negative. So HLA-B27 may be positive. Here it is reactive. So there is usually a history of fever or some infection in the past. So usually one specific infection is related, that is non-gonococcal urethritis. So usually non-gonococcal urethritis, it leads to a triad. As we know, arthritis. That arthritis will be a mono or oligoarthritis. It is not polyarthritis, it is mono or oligoarthritis. Oligo is 2 to 6 joints. 2 to 4 joints is oligoarthritis. Usually knee joint or elbow joint. So usually large joints are involved. Rheumatoid arthritis involves small joints. Reactive arthritis involves large joints. So there is arthritis, conjunctivitis with the background of urethritis. There may be uveitis also. Like we discussed the features of spondyloarthritis, uveitis is a common feature. So this triad is called Rhetus triad, which we know. A Rhetus syndrome or Rhetus triad. So this is about reactive arthritis. Then psoriatic arthritis we discussed. IBD related arthritis is, there's a history, current history or past history of ulcerative colitis or Crohn's. This also involves larger joints. So this finishes the next component of autoimmune disease, which is arthritis evaluation. So now we'll finish vasculitis. Vasculitis is blood vessel involvement. So we can classify blood vessel involvement like this: primary vasculitis and secondary vasculitis. Secondary vasculitis is simple. Some disease is causing vasculitis. For example, we already discussed SLE can cause vasculitis. Rheumatoid arthritis can cause vasculitis. Sarcoidosis can cause vasculitis. There can be paraneoplastic vasculitis. Two viruses are typical for causing vasculitis: hepatitis B and hepatitis C. So when discussing hepatitis B and hepatitis C, we would have heard about the term called as cryoglobulinemia. That is, antibodies will be increased in the blood in these infections. Those antibodies will affect the blood vessels, especially in dependent bonds. So we'll have a finding called as livido reticularis in the leg. Livido reticularis is nothing but a net-like skin discoloration in the leg because of blood vessel destruction. There can be palpable purpura. palpable purpura. This is the classical finding of vasculitis. So a skin discoloration or a palpable purpura will be the skin manifestation of vasculitis. Plus, where all blood vessels are small, there can be involvement. So usually kidney has very small blood vessels. So usually most of the vasculitis will have glomerulonephritis. Okay, usually most of the vasculitis will have glomerulonephritis because glomerulus is nothing but a bunch of capillaries, small blood vessels. Only one disease does not cause glomerulitis, that is polyarteritis nodosa. It causes renal involvement without glomerulonephritis because it doesn't involve the smaller joints, it involves the larger joints. Okay, so usually the features which we are now discussing, they are features of small vessel vasculitis. The symptomatology of vasculitis depends upon the size of the vessel which is involved. So the classification of vasculitis will be two types. One, secondary vasculitic syndromes and primary vasculitic syndromes. Secondary, always remember hepatitis C. Hepatitis B causes cryoglobulinemia. It affects the small vessels causing livedo reticularis, palpable purpura and glomerulonephritis. And we have primary vasculitic syndromes. The primary vasculitic syndromes, it will be easy if we classify them according to the size of the vessel like this. So aorta is the largest vessel, right? So aorta and its major branches or the large arteries are large. Then we have medium-sized arteries and arterioles. But once we come to the capillary and venules, these are the small vessels. So primary vasculitis can be classified based on the size of the blood vessel it involves into large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis. Based on the type of vessel involved, the symptomatology varies, the diagnostic approach varies, treatment varies, right? We have only two main diseases in large vessel vasculitis. One is giant cell arteritis and Takayasu arteritis. We have two diseases in medium vessel vasculitis, which is polyarteritis nodosa and Kawasaki disease. In small vessel vasculitis, we have so many diseases which we'll discuss. So large vessel vasculitis, I told giant cell arteritis and Takayasu arteritis. Giant cell arteritis, the clinical scenario is very, very typical. It usually affects males. Usually all autoimmune disease affects females. Only few are affecting males. Like one disease is ankylosing spondylitis, which affects females. Second, gout, which affects males. Ankylosing spondylitis affects males. Gout affects males. This giant cell arteritis affects males. So how will be the presentation? Headache. Because large vessels affecting the head, superficial temporal arteries affected, so there will be headache. Plus there can be visual changes, blurring vision. So males more than 50 years, headache, blurring vision will be giant cell arteritis. Usually this giant cell arteritis will be affected with peripheral joint pain also. That is called as PMR, polymyalgia rheumatica. Here the inflammation is not involving the joint directly, but this comes as a systemic reaction. So there will be headache plus polymyalgia rheumatica and giant cell arteritis. Okay. Then we have Takayasu arteritis. Takayasu arteritis is a large vessel vasculitis which occurs in less than 50 years. Takayasu is called as pulseless disease because other arteries are involved. So I'll show you, we'll discuss that separately now. Now coming to medium vessel vasculitis, we have two important diseases. One is polyarteritis nodosa and Kawasaki disease. This Kawasaki disease is commonly discussed in pediatrics as MCLN syndrome, mucocutaneous lymph node syndrome. The name itself suggests it affects the mucosa, it affects the skin, it affects the lymph nodes. So mucosa, how does it affect? It causes a finding called a strawberry tongue. So vasculitis is there, so the presentation will be like fever, joint pain will be there. strawberry tongue will be there. In skin, it causes thick palm, thickening of the palm. There can be lymph node enlargement. There can be skin peeling actually. Skin peeling from the palms. So this is mucocutaneous lymph node syndrome. So it is picked up by clinical examination. A child presents with fever, joint pain, strawberry tongue is there, oral ulcers are there, skin peeling is there, lymph node enlargement is there. It is labeled as mucocutaneous lymph node syndrome. But why it is important to understand Kawasaki disease is it is a medium vessel vasculitis. Coronary arteries are involved here. Okay, coronary artery is also a medium vessel. So coronary arteries are also affected in Kawasaki disease. Even though it may not be affected initially, in late stages it may cause coronary artery ectasia or coronary artery dilatation or coronary artery aneurysms. That is why it is important to diagnose Kawasaki disease. So Kawasaki disease, mucocutaneous lymph node syndrome, coronary artery aneurysm is there. We are treating it with IVIG. So why this Kawasaki disease is important is polyarteritis nodosa is also a medium vessel vasculitis. The pathology both are causing necrotizing arteritis, but there is no mucocutaneous lymph node involvement in PAN and there is no coronary artery involvement in PAN. Okay. So Kawasaki disease is dangerous because it causes coronary artery aneurysms. Polyarteritis nodosa is not going to affect the coronary arteries. We already discussed another specific feature of polyarteritis nodosa. It does not cause glomerulonephritis. Okay, it involves the kidneys without glomerulonephritis. So now coming to small vessel vasculitis. The small vessel vasculitis is the one which is challenging because clinically it presents with many features. As I told you, it causes livedo reticularis. It causes palpable purpura. And wherever small blood vessels are there, it will get affected. So I told you kidney. So glomerulonephritis is a very typical finding here. It can affect the lungs. Lungs also have small blood vessels. It can affect the GIT. So there can be diarrhea. There can be GI bleeding. So all these features are small vessel vasculitis. So I told you whenever these features are present, how will you evaluate? We are going to find out whether antibodies are there or not. So there are some small vessel vasculitis where immune complexes get deposited in vessels. Immune complexes are antigen antibody complexes. When they are getting deposited, when there is immune complex deposition, it is usually secondary. Okay, when immune complex is deposited, it is usually secondary. We discussed secondary shortly already, like lupus vasculitis, rheumatoid vasculitis. There is something called as Henaut-Schönlein purpura. Henaut-Schönlein purpura is an IgA vasculitis where IgA gets deposited in the blood vessels. We have cryoglobulinemic vasculitis. We discussed about hepatitis B and hepatitis C. So usually these secondary diseases will produce antigens, antibodies will be produced, those complexes will get deposited in the vessels. This is the pathogenesis of immune complex vasculitis. So since we discussed about IgA vasculitis, we already discussed HBV and HCV related cryoglobulinemia. IgA vasculitis is also called as Henaut-Schönlein purpura. This is important because this is also an important feature occurring in pediatric population, pediatric or young adults. The other one which we discussed was Kawasaki disease or mucocutaneous lymph node syndrome. So Henaut-Schönlein purpura being a small vessel vasculitis, there can be legs and gluteal region will show palpable purpura. Kidneys are involved, so it causes glomerulonephritis. So what will be the presentation here? Hematuria. The GIT is involved, so there can be abdomen pain with the GI bleeding. Hematochezia can be there. So they usually don't end up with the rheumatologist, they end up with the gastroenterologist or they end up with the urologist. Okay, so it is important to recognize IgA vasculitis, plus there can be fever. Okay, it is self-resolving as steroids can be given. So the other category of small vessel vasculitis is primary small vessel vasculitis, where this immune complex deposition is absent. So if immune complex deposition is not there, we cannot diagnose it by biopsy. So all these diseases can be diagnosed by biopsy. Glomerulonephritis, lupus nephritis can be diagnosed by kidney biopsy, renal biopsy. Whereas if there is a pauci-immune deposit, if there is no immune complex deposit, we call it as pauci-immune deposit. There is no immune deposit. So how will you diagnose? We are having an ANCA, anti-neutrophilic cytoplasmic antibody. It is not anti-nuclear antibody, it is anti-neutrophilic antibody. We have two types of ANCA. P-ANCA, which is peroxisomal anti-neutrophilic cytoplasmic antibody, and C-ANCA, cytoplasm. So P-ANCA and C-ANCA. So we have three diseases in that. So one is GPA, granulomatosis with polyangiitis. Previously this was called as vaginous granulomatosis. So again the same thing, kidneys are involved causing glomerulonephritis, lungs are involved causing lung cavity. It's not only the lung, the upper respiratory tract, the nose, the sinuses are also involved. Then we have eosinophilic GPA, EGPA, eosinophilic granulomatosis with polyangiitis. It is called as Church-Strauss syndrome. So when eosinophilia is present, what additional feature will be there? Bronchial asthma will be present, right? So one of the causes of refractory bronchial asthma or a secondary bronchial asthma, there are many reasons for diseases presenting with bronchial asthma, right? One is occupational asthma, allergic bronchopulmonary aspergillosis, which we are discussing in pulmonology, and EGPA, Church-Strauss syndrome, is also a cause of secondary bronchial asthma. Here also we have glomerulonephritis. So these two diseases can cause pulmonary bleeding, right? So whenever there is small vessel vasculitis, bleeding will occur from somewhere, either GI bleeding or hematuria or lung bleeding. Okay. So when there is lung bleeding plus kidney bleeding, think of GPA, Church-Strauss syndrome. Another disease is there, which is Goodpasture syndrome. Goodpasture syndrome is also an autoimmune disease where there is IgM deposit in the glomerular basement membrane. We discussed the antibody in our first table, call for A3, okay, collagen 4 alpha 3. And the other vasculitis is microscopic polyangiitis. It is also a small vessel vasculitis with pauci-immune deposit, without asthma, without lung involvement, only kidney involvement, MPA. Okay. So this is the complicated version of this vasculitis, but this will cover everything. So maybe you can take a screenshot of this. So just we'll quickly revise whatever we had discussed. So vasculitis, I told, two ways of classifying, secondary vasculitis or primary vasculitis. Another way of classifying is large vessel, small vessel. So granulomatosis with polyangiitis is a small vessel. Microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, IgA vasculitis, cryoglobulonemic vasculitis. These are the small vessel vasculitis. Pan and Kawasaki are medium vessel vasculitis. Giant cell and Takayasu are large vessel vasculitis. We have some special types of vasculitis like Behçet's, Cogan syndrome, etc. In that Behçet's alone we'll discuss. So if a scenario is given that patient has fever, patient has glomerulonephritis, patient has arthritis, patient has palpable purpura, plus this finding. So you can see multiple lung cavities. So this diagnosis is GPA, granulomatosis with polyangiitis or vaginous granulomatosis. So vaginous granulomatosis is a small vessel vasculitis, pauci-immune vasculitis. So how will you diagnose this? By C-ANCA. Okay. So we are diagnosing this by C-ANCA. So the lung feature here will be multiple cavities and they are called as fleeting cavities. Like one cavity will be present today, 2 days after if you do an imaging, these cavities will disappear and new cavities will form. So, okay, polyarteritis nodosa. And EGPA we know, the same finding with bronchial asthma, it is called EGPA. If there is only kidney involvement, glomerulonephritis without lung involvement, it will be microscopic polyangiitis. So that is about small vessel vasculitis. See, PAN is one, medium vessel vasculitis. So I told you, coronary artery is not involved in PAN. Okay, but on the contrary, Kawasaki disease, coronary artery aneurysms are very common. But which artery is involved more common in polyarteritis nodosa? It's the renal arteries, renal and muscular arteries. So there can be renal failure, but it is not glomerulonephritis. Okay, so the renal artery is involved without glomerulonephritis in polyarteritis nodosa. See, cardiac is less common. Now what about Takayasu arteritis? Sorry, polyarteritis nodosa. Okay. Coming to Takayasu arteritis, this we didn't discuss in the initial graph. Takayasu arteritis is also a condition where coronary arteries are least involved because it is a large vessel vasculitis. So previously some questions were asked about this finding. Will coronary arteries be involved in Takayasu arteritis? No, because it's a large vessel vasculitis. So either aorta or its branches, major branches are involved. So subclavian is the major artery which is involved. That is why it is causing a pulseless syndrome. Takayasu is called as pulseless syndrome. So arm claudication, Raynaud's phenomenon is present. So vascular ulcers may be present. Common carotid is the next. See, coronary is least involved because it is not a large vessel vasculitis. See, pulmonary is also less involved because pulmonary is involved in medium and small vessel vasculitis. Okay. So, which artery is commonly involved in giant cell arteritis? The temporal arteries. Which artery is commonly involved in Takayasu arteritis? The subclavian artery. Least involved is coronary artery. Which artery is involved in PAN? Renal artery is commonly involved. Coronary artery is least involved. Which artery is involved in Kawasaki disease? It is coronary artery causing aneurysms. Okay. So Behçet's. So we finished vasculitis. I was telling you one special kind of vasculitis is Behçet's syndrome. Remember we are discussing about mucocutaneous lymph node syndrome, which is Kawasaki disease. Likewise, you remember another one name, which is oculo-orogenital syndrome. Oculo is eye, oro is oral cavity, genital. So oculo-orogenital syndrome is nothing but Behçet's syndrome. The criteria is also there because there is oral ulcers, ocular ulcers, genital ulcers. So oral is the main finding. So there must be oral ulcers, recurrent oral ulcers. So how recurrent? 3 times in 1 year. So the criteria for Behçet's syndrome is oral ulcers. There should be recurrent oral ulcers in 1 year. That is 3 recurrent ulcers in 1 year. Plus there should be 2 of these 4 features. It could be genital ulcers, eye lesions, skin lesions. Eye lesions can be uveitis or vasculitis. Skin lesions can be erythema nodosum, etc. And scarring genital ulcers can be there. There's something called as Petherji test. Petherji is like a skin reaction. It's like a Mantoux test for tuberculosis. It's a skin reaction test. It is read 28 to 48 hours after insertion. The Petherji test is done in Behçet's disease. So oculo-orogenital syndrome, oral ulcers is the criteria. Recurrent oral ulcers 3 times in 1 year plus 2 out of 4 genital ulcers, skin lesions, eye lesions and Petherji. Okay, so that completes vasculitis. Now coming to the last aspect of systemic autoimmune diseases, we discussed about the 3 systemic conditions, which was SLE, Sjogren's and scleroderma. Then we discussed about vasculitis, then we discussed about arthritis. Now myositis, inflammation affecting muscle. So just a summary slide. Dermatomyositis is the most common disease. Females are affected more than males. Usually in any autoimmune disease, females are affected more than males, except a few diseases. One is ankylosing spondylitis, one is gout, large vessel vasculitis, that is giant cell arteritis, then inclusion body myositis. So dermatomyositis is common in children. So dermatomyositis, skin and muscle is involved. In skin we have rashes. I'll show you the rashes. Usually, when do we say muscle is involved? So in our neurology discussion also we are discussing. In muscle there will be weakness. It will be a proximal weakness usually. Of course there are distal myopathies also, but there will be proximal weakness. Reflexes are reduced, but they are not absent. Because only in neurological diseases reflexes are absent, so reflexes are reduced. We diagnose it by EMG. Don't confuse myositis with muscular dystrophies. Muscular dystrophies are congenital conditions. Example, Duchenne's and Becker's muscle dystrophy are congenital conditions where there is problem in the muscle proteins. Myositis is an inflammation which causes autoimmune damage to the muscle proteins. So proximal weakness is more. When muscle is damaged, what will rise? Creatine kinase will rise. Okay. So the symptom is proximal weakness plus skin changes. Basic test is creatine kinase. When creatine kinase is very high, that will cause myoglobinuria, that excess muscle protein will be excreted in urine called as myoglobinuria. It can lead to acute kidney injury. And what is the specific test? We can do some antibodies. That antibody is anti-MI2. If you are able to remember this, please remember anti-MI2. We can do muscle biopsy. We can do MRI also. We can do MRI thigh to see the muscle. We can see muscle inflammation there. Thigh to see muscle inflammation. Okay, so clinical feature, basic test is creatine kinase, antibody is anti-MI2, MRI thigh we can see, and final confirmation is by muscle biopsy where we have specific features. Dermatomyositis is very important because other diseases like ILD, myocarditis are also there. Then we have polymyositis. Here there is no skin involvement. That is the only difference. Here also females are involved. Polymyositis is common in adults than in pediatrics. Here also we have proximal weakness, creatine kinase is elevated, MRI thigh can be used, and anti-MI2 is negative. Muscle biopsy shows a different finding. Then we have something called as antisynthetase syndrome. Here again the same features. Antisynthetase syndrome, we have antisynthetase antibody. Okay. If there is myositis, we have to send anti-MI2 and antisynthetase antibody. Here we have some specific features like mechanic sense. So I'll write it down. There is myositis. There is mechanic sense, ILD, arthritis, Raynaud's. If these 5 features are present, we call it as antisynthetase syndrome. Okay, when do you say dermatomyositis, skin is involved, muscle is involved, there may be ILD, right? Okay. Then inclusion body myositis. Why inclusion body? Because inclusion body is the feature in muscle biopsy. Here again there is no skin rash. In inclusion body myositis, males are commonly involved. Proximal weakness is more, creatine kinase is elevated, and the same features. Here dermatomyositis is important. Polymyositis is the same features like dermatomyositis but no skin involvement. If there is associated arthritis, mechanic sense and Raynaud's, we call it as antisynthetase syndrome. See, if the scenario is given, patient is having muscle weakness, elevated creatine kinase with these features. So what are these features? Can you see macular plaques? These macular plaques are called as Gottron sign. Macular plaques are called as Gottron sign. The papules are called as Gottron papules. This is called as heliotrope rash. Heliotrope rash is like a sunflower. The sun exposed areas alone will get a rash. That is called as heliotrope rash. Then see the V sign. This looks like an inverted V. So Gottron sign, which is macular plaques, Gottron papules, which are erythematous papules, the shawl sign in the neck, the V sign in the anterior neck, sorry. This is the shawl sign. And these together are called as heliotrope rashes. So when this is present, we call it as dermatomyositis. So remember, muscle disorders, if they are congenital, we call it as muscular dystrophies. Congenital muscle diseases are called as congenital muscle dystrophies. If they are acquired diseases, we just give the name myopathy. Myopathy can occur due to any reason. It could be metabolic myopathy. For example, Cushing's causes myopathy, muscle weakness. Hypothyroidism causes muscle weakness. Some electrolytes causes muscle weakness. That is metabolic myopathy. It could be inflammatory myopathy. Inflammatory myopathy is called as myositis, which we are discussing now. Right? The polymyositis, dermatomyositis, antisynthetase syndrome and inclusion body myositis. It could be traumatic, like when there is a necrotizing fasciitis or when there is a compartment syndrome, muscles go for trauma. Compartment syndrome. Some drugs can cause myopathy, like statins can cause myopathy, right? Statins, fibrates can cause myopathy. Why statins cause myopathy? Because statins inhibit HMG-CoA reductase. HMG-CoA reductase is the first step in cholesterol synthesis. One co-product of cholesterol synthesis is coenzyme Q. Coenzyme Q has an important place in ATP transport, electron transport chain, ATP metabolism. In electron transport chain, coenzyme Q has a role. So muscles will not have ATP, so muscles will go for myositis, muscle pain, myopathy. Then we have some biochemical causes. When some enzymes are deficient, for example in McArdle's disease, a muscle enzyme is deficient, so muscle metabolism will be affected. That will lead to muscle pain. Okay. So this is just about telling the additional features in dermatomyositis. I told you there can be ILD, there can be liver, spleen, skin, eye involvement, etc. Now the last part of rheumatology will be crystal arthritis. So we are just discussing about inflammatory and non-inflammatory arthritis. So one important feature is crystal arthritis. So some crystals can get deposited in the joint to cause arthritis. So in that we have two, gouty arthritis and pseudogout. Gout and pseudogout. In gout, uric acid or urate crystals are deposited. Why these crystals deposit? Because whenever temperature becomes low in peripheral joints like metatarsophalangeal or ankle joints or finger joints, whenever temperature becomes low, this favors crystallization. So there are some prerequisites for crystal formation. One, there should be high supersaturation of the particular product. For example, in gout I told you uric acid. So when uric acid levels are high in the blood and when the temperature in the peripheries are cold, this uric acid deposits in the peripheral joints. Pseudogout is nothing but deposition of calcium. So a calcium pyrophosphate deposition disease. calcium can be calcium pyrophosphate or calcium apatite crystals. Whatever the type, calcium gets deposited in pseudogout. So this occurs in conditions causing hypercalcemia. Okay. So there are so many reasons. So there are many genetic reasons causing hyperuricemia. So for example, the Lesch-Nyhan syndrome. So product with uric acid metabolism. So some medicines can increase gout. So some diuretics. Aspirin, obesity, alcohol, high protein diet. So the dietary factors, habit factors like alcohol, some drugs, all these things can be risk factors. Then I told you what triggers crystal formation. Uric acid should be high and temperature should be low. Plus that can be additional features like dehydration, intra-articular dehydration, the pH, etc. So something usually triggers. For example, there can be diuresis and acute dehydration or an acute illness leading to dehydration. Okay, sudden change in urate levels, purine-rich food, okay, alcohol. So usually these will prefer. So when these factors occur, uric acid crystallizes. Uric acid crystallizes as monosodium urate. That is the crystal which is formed. So monosodium urate is the crystal which is formed. So it causes gouty arthritis. So what type of arthritis is gouty arthritis? It is a monoarthritis. So there is severe pain. There is a severe pain, severe swelling. It can be so severe that it can even cause fever. Which joint is commonly involved? The first metatarsophalangeal joint, that is the toe, the great toe. First metatarsophalangeal joint is commonly involved. Of course, other joints can also be involved like ankle joint, etc. So there is some triggering factor, predisposing factor, and this will be the typical clinical presentation. One important thing is blood uric acid levels may be normal during an acute gout. Many people get confused that when there is arthritis but uric acid level is normal, it still could be gout because the excess uric acid deposits in the joint. That's why gout occurs. So in acute gouty episode, blood uric acid level may be normal. So treatment here is, again like in rheumatoid arthritis, treatment here is important. One is the symptom management. We give paracetamol, NSAIDs. One specific symptom management is colchicine, which is an anti-inflammatory. We can give 0.5 milligram TDS to Q6 thoroughly. It's an anti-inflammatory. Then what is the pathology changing treatment, which is we are going to lower urate. So the urate lowering therapy can be allopurinol and febuxostat. These two drugs reduce uric acid formation. So how do they reduce uric acid formation? These are called as xanthine oxidase inhibitor. Xanthine oxidase is an important step in uric acid formation. So when xanthine oxidase is inhibited, uric acid production becomes low. So and by far this is the best method to treat chronic hyperuricemia. Please remember, these drugs do not have an acute role in gout. When there is an active gout, we are supposed to give painkillers, colchicine, and treat the triggering factor like alcoholism. We are supposed to change the diet, hydration, etc. But when that acute episode settles, to prevent any acute fluctuation in uric acid levels, it should be the xanthine oxidase inhibitor should be started after the acute episode of gout resolves. Of course, there are other drugs. Probenecid is an uricose uric drug. It causes excretion of uric acid. These drugs are not usually used because it can cause uric acid stones. Because excess uric acid can form stones. Uricase, for example, rasburicase, these are enzymes which break down uric acid. These are used in an emergencies. So there are some conditions where uric acid becomes very high. Like whenever the cells go for lysis, like rhabdomyolysis, or hemolysis. When do cells form and get destroyed? When we are giving chemotherapy for tumors. So in tumors, cells form more. When we give chemotherapy, those cells get less and uric acid becomes more. So when chemotherapy is initiated for blood cancers, when there is rhabdomyolysis and when there is hemolysis, uric acid will be very high. We are supposed to give rasburicase. Okay. So this is what I was telling you. NSAIDs, colchicine, steroids and paracetamol is given in acute flare. But to prevent the urate lowering treatment, we are going to give allopurinol, febuxostat, probenecid and uricase, rasburicase. So this imaging is the monosodium urate. See the needle shaped crystals. So they describe it as needle shaped crystals. So in where you can take the sample from the painful joint. So there is swelling of the joint. If you do a needle aspiration and see it under the microscope, you can see needle shaped crystals of monosodium urate. If you see under polarizing microscope, it will be negative birefringent. So negative birefringent needle shaped crystals. On the contrary, see this like envelope cover shaped or hexagon shaped crystals. This will be CPPD, calcium pyrophosphate crystals. This is monosodium urate crystals. Okay. So this completes our entire rheumatology.